Hi, everyone. Welcome to another question and answer session with Dr. Drossman and myself. Today, we are going back to pediatric GI care. We've had a few videos with guest experts talking about pediatric care and GI, and today we're joined by another guest, Dr. Jordan Shapiro, who is going to talk to us about the importance of transitioning pediatric GI patients to adult care and how that needs to look for maximum benefit for patient and provider. So hello to Dr. Drossman and hello to Dr. Shapiro.
Hey, Joanna. Hi, Jordan.
Hi.
How are you?
I'm great. How are you, sir?
It's nice to meet you. Just for those of you out there, Jordan Shapiro is a pediatric gastroenterologist who is now currently working in practice, doing practice and research. He's with the integrated gastroenterology practice. He got his Med-Peds fellowship training at the University of Cincinnati and then did clinical research in Houston. And really, to start, as a practicing gastroenterologist, I very often get patients transitioning. I hear them from UNC, from adolescents who come to me. I'm kind of interested in your thoughts about what I should be prepared for and what the adolescents should be prepared for. How do we make that transition? And what should patient and doctor know about?
Sure. So I'm delighted to be here and talking on this topic, which is very near and dear to my heart. I think that one of the things that quite often comes up is I think on both sides tend to, from a system standpoint, the pediatric physicians often struggle with understanding where they're sending their patients. So they may have had this very long standing relationship with a patient and their parent. And the parent may have actually been one of the most or the most important part of the care team, may have received a lot of the information from the doctors and the nurses in pediatric care. And all of a sudden, when they sever that relationship and go to adult care, this dyad of parent and patient that were being cared for, all of a sudden, all of the energy and focus is on the patient. I think when they come to adult care, we often don't know what to do with the parent. And they may be, there may be some awkward moments where they're trying to, in our view, answer most of the questions. And that's really just the system they came from and the model of care that they were in. So I think pediatrics tends to be much more family-centered care. And in the adult world, we're patient-centered, and there's a bridge that needs to exist in order to kind of smooth out the experience for everyone.
Yeah, and we actually did a video with which we can provide to the audience if they contact Johanna about the parent overriding the discussions of the adolescent. So it's a common phenomenon.
Yeah, and I think,
go ahead.
I was going to say, I think it's one of those things where it's always a bit of a dance, but I will often try to preempt the conversation and just let them know, I'm really grateful you're here. I will acknowledge the loss that they've had of the relationship to not only the pediatric provider, but the pediatric system, which is often much more robust than we have in adult care. If they miss an appointment, someone is calling them immediately to reschedule. If they miss a lab draw, someone is reaching out and asking if they're okay. And in adult medicine, we tend to sometimes just at least think, if not say, well, you're an adult, and so if you don't want to take care of your health, that's your problem. So I think I'll try to preempt the conversation when I have a parent and a patient in the room and just say, really, I know you lost a relationship and someone you may have been with for many years, and it's going to take us time to build a similar relationship, but I'd love to do that. And I'll acknowledge that a lot of the questions and answers were directed to and given by parents, and that I want to be part of the team that helps both of them transition to the patient being more at the center of their care team, with the parent not gone, but not playing as central of a role over time. So I'll often start with something as simple as, I'm really glad you're both here. I'm going to give Joe the patient an opportunity to answer first, and I would love at the end to make some space for you to add anything that you think is important. I think it tends to de-escalate what can often be a really tense situation for parents. I mean, they come in sort of, if not visibly, like figuratively kind of clinging to their child, because they're often quite anxious and quite scared about the new environment.
What is the transition year that's usually done?
That is a great question. And I would be lying to you if I said that there's a right answer. I think historically that's been very institution dependent. So there are some institutions where the pediatric institutions will try to get patients moved to adult care by 18, by 21. The more tertiary and quaternary care the facility is, I won't name names, but I think several of the places that I've trained in, they tend to take care of such niche patients in some areas of gastroenterology and just in general that they don't have anywhere that they can transition them to or transfer them to. So in those cases, some of those hospitals will keep patients in their liver clinic until they're 40. And then it becomes obvious to everyone that it's a problem, because from a safety standpoint, the pediatric nurses aren't really comfortable taking care of a 40-year-old. But I think in general, part of the focus has been on not too early and not too late. And we know that in the later teenage years, some of the transition readiness assessments that look at things like knowledge about disease and self-advocacy and self-management skills, that most patients tend to start scoring better on those around 18, 19, 20. So I mean, I think in general, most physicians try to shoot for between 18 and 21, but there's quite a bit of variation.
So what are the key elements that the child, the adolescent, goes through when they're transitioning from one to the other? What is it the pediatrician is providing, and what is the adult providing, and what is that like for the patient?
Sure. Historically, and I say historically, I think the norm is still that it's really more of a transfer, and it might be a good point in time to sort of distinguish this term transition versus transfer. So transition is meant to be a process, which I think by definition means it's not a one-time visit in which we say, I think it's time to go to adult care. Why don't you call this adult provider and schedule an appointment? It really should be a process. And the guidelines for this are put out by GOT Transition, which is sort of a collective of pediatricians and internists and family practitioners. They actually recommend starting transition discussions as early as 12 to 14. That may be as simple as discussing on the pediatric side that this will eventually happen. And then each visit, slowly shifting the focus a bit to the pediatric patient, around 14 in an ideal setting. Doesn't mean that happens most of the time. It's actually recommended by the American Academy of Pediatrics that we have the parents step out of the room, which is another conversation that takes some practice to get good at, and just give some time to the patient. And it's not, I tell parents, my conversation is often, this isn't just to talk about the things you're terrified of us talking about, like sex, drugs, and rock and roll, but it's really just to get them comfortable conversing with physician and their care team, because in a few studies, that was one of the best predictors of, quote, transition readiness, was actually how comfortable the patient was communicating with their physician. And then, as you get closer to the older adolescent years, 17, 18, 19, then you start actually looking at, where are you likely to go? Are you going to go away to college? Do we need to look for a provider there? Who's going to be the recipient, the adult provider recipient? And then putting together, the guidelines recommend a transfer summary. That's just some highlights of the patient's care, what they've been through the treatments, an emergency plan. And then after all of that, in an ideal setting, is when the actual transfer happens, where you schedule the first adult appointment. There are different models. I don't know that any have been shown to be the best, of whether they go to the adult provider and go back to the pediatric provider for a one-time follow-up, just to kind of iron out any troubles. And then they're established in adult care. And in the guidelines, that still doesn't really end the transition process, because there's still quite a bit of skills and knowledge acquisition, even once established in adult care. So that's kind of the highlight from the GOT transition guidelines.
You kind of alluded that for the pediatrician, it can sometimes be a loss. Do you ever get a pediatrician who hangs on?
Yeah, I think to the question about whether or not pediatricians sometimes hang on to patients longer than is ideal, I think yes. And I would say there are a number of drivers. One is just they've established a relationship with the patient and the parent, and I think that's hard for any of us to let go. We don't think about that in adult medicine as much, because we have a lot longer period of time to take care of patients. Sometimes in those instances, it really is just the lack of understanding of how to have the conversation and introduce it early. I've seen a lot of patients when I used to go over to pediatric GI clinics where it's chronologically time, but as soon as a conversation comes up, the parent or patient says, no, I think we'd like to stay here. And that's sort of the end of the discussion. And then I think there are other times which maybe are the riskiest for the patient, where the transfer is driven very abruptly by a change in insurance, for instance. So the Medicaid population, at least in the IBD literature and diabetes literature, when you look at transition, those patients, the day they turn 19 in many states, lose their insurance and lose access. And then the other one historically that's been a problem has been if an older teenage patient becomes pregnant, that it often signified the end of childhood, and they were abruptly sent to the adult hospitals. And so, I think I've had a few instances where I've had pediatric GI doctors call me with patients who became pregnant who had, bad irritable bowel syndrome, or even Crohn's disease and more complex treatments. And I've actually kind of helped co-manage them so that they didn't have another trauma that they had to go through by having a child and also losing their care team that they're familiar with. So I think those are always difficult situations. But I mean, most of the time when it doesn't happen on time, it's really just we start the conversation too late, and it's a bit awkward unless you try to do it the same. And so one of the things in the guidelines that's recommended as the first step is to actually have a policy that's just very transparent. We transition patients or try to transfer them to adult care at this age. We will start the conversation at this age. But like most guidelines, the adherence to those is not great. But
what's your experience with the adolescent who comes to you? What are the ways in which they're reacting, and how do you? I mean, some may want to stay, how do you address that with them?
I try to tell them the same thing I tell my 80-year-old patients, that I'm happy you're here. And sometimes I'll just ask them, how does it feel being on the adult side for the first time? Is it scarier than you thought it was going to be? Is it better than you thought it was going to be? And I love asking them. I think pediatricians do a much better job at this than we do in adult medicine, about asking them what they're doing in life. I'll try to understand who is in the room with me, because that's one of the things that never comes over with the medical records from pediatric care is, who is this? And so I've actually stipulated that when I get records sent for patients who are transitioning to me, that I want to know one thing about them. So, this is a bassoon player who wants to go get his PhD in music therapy, or this is a freshman who has no idea what they want to do, but they really enjoy surfing, or whatever it may be, because it allows you to walk into the room with some information that I think that the pediatricians are good about that, because they're with those patients through a lot of milestones. You ask, okay, what grade are you in this year? What do you like to do with your friends? And in adult medicine, our social history tends to be a little bit more fact-finding than just curious. It tends to be more, tell me about substance abuse, tell me about maybe your occupation, but we're thinking about it like what occupational hazards are there? And it's less about like, who are you? Like,
Yeah.
So I think that tends to be a good way to start, not just adolescent visits, but in general.
In many ways, anyone who's had an adolescent child, you have, Johannah, right? know that they're kind of a different sort of people. And when doctors are used to talking to adult patients and they transfer that onto the new adolescent, there may be some communication gaps. I mean, their world, you said sex, drugs, and rock and roll. There's a lot of things about their world that are different, where the adult gastroenterologist may not know how to communicate and may not get the information. Can you say what some of the generic issues are that might be difficult for the adult gastroenterologist, and how can that be reconciled?
Yeah, I think, I mean, it's an age, I try to reflect a lot on my own adolescent time, and also I think going back and forth between the pediatric and adult worlds in training, I think gave me as much perspective as I can have without having my own adolescent yet. Although my 4-year-old sometimes acts like he wants to be an adolescent, but I think it's to me, it's a really fascinating time of just, they're learning so much so quickly about becoming an individual, about having a choice, about being able to make choices even that aren't necessarily, quote, the best or good. And I think that a lot of times when they come to adult care, I try to just reflect back to them how exciting that time is. And I try to let them know that, I talk to patients about all kinds of things. And if they ever want to have a visit where we just talk about, the challenges of taking the disease process they have, or condition they have, to school, or how it impacts sex, that they may not want to talk about it that visit, but I try to make everything okay and worth the time. Because I think
that's done without the parent in the room.
Correct. Yes. And I think, one of the things that comes up a lot of the time with the parent out of the room is there's how do you get the parent out of the room? But then there's also once the parent's gone, being really explicit about confidentiality. Do you understand what that means? Do you understand, if they're over 18, then especially, but then, this is information that stays between us, whatever it is. I think the sticky situation is sometimes when they're under 18, that there are a few instances with threat to self or to others in which it does need to be disclosed. And those are conversations that I think, like any difficult conversation, I practiced them a lot, and I've had those come up where it may be a patient that starts out with a conversation about an eating disorder that they've never discussed with anyone, and then the parent's out of the room and they're 17, and as we kind of explore some of the drivers of that, there's some suicidal ideation, and those are really those are some of the most difficult conversations, because you have to notify parents of this. But in general, I don't know. I think there's this John Steinbeck quote that I always misquote, despite it being my favorite quote. That's just something along the lines of, I wonder how many people I've passed, in my life and never seen. And sometimes as much technical stuff as we accrue in our heads, I think like part of our job is to help people feel seen. And I think especially for teenagers who there's a lot of moving parts in their life, like their medical transition, their medical care transition is like the smallest of the transitions they're making often. They may be going to school, they may be looking for a job, they may be going to the military. And I think just seeing them for what a challenging time it is and has some
very insightful comments. Before we end, I just wanted to come back to another question for you, which is what about when the adolescent is disclosing information under 18, but there is no threat talking about sexuality or use of drugs, where there's no clear evidence of risk? How do you handle confidentiality in that situation?
I let them know. I mean, I start every conversation when a parent leaves the room, even if I've seen them 4 or 5 times with, I want to just reiterate that everything is confidential with these exceptions. If they do disclose that they've been experimenting with whether it's sex or substance, I'll have a conversation with them that sometimes is a little bit generic, just in that, as a gastroenterologist, sometimes I encourage conversations with, if there is another provider, like a primary care provider, I'll say, have you ever talked about this with your pediatrician or your family doctor? But I'll let them just talk it out, I think. And I'll let them know to kind of close it. I sort of sandwich that information in explicit conversations about confidentiality. I take reporting. I've helped several patients report, sexual abuse, and not necessarily just adolescents, and coach them through, how that process goes with law enforcement. And I think the things that were mandatory reporters for, I take very seriously. But I also look back at my adolescence and think the people who allowed me to kind of have some bumpers to experience life without necessarily pushing too hard, I think they have enough people. And ultimately, those conversations, I think, are so sacred because we're not just doing them so that they'll keep coming back and talking about their diarrhea or their abdominal pain, but those have the opportunity to both facilitate the medical care that we're trying to give and also to, I think, make you a confidant if they do have a moment or a period of time where they're starting to feel suicidal or they're doing something risky, they realize that you're a safe person. I think those, as hard as those conversations are, they're some of the most sacred ones that we have in medicine, where somebody confides something like that to you.
Very, very helpful. Well, I want to thank you for your insights. And I hope this will be helpful to those of you out there. Johannah, any further comments or questions?
Oh, I think it was really interesting and very helpful for parents who have maybe early adolescent children who are beginning that process, even if they're not in GI, a GI patient, just transitioning to adult medical care. So thank you, Dr. Shapiro, for being with us today. If you have any questions for him, please let us know, or we'll be happy to send those along and get some answers for you. Until next time, everyone, take good care, stay safe, and we'll talk to you again soon. Bye now.
Take care, everybody.